Okay, San Jose State University, March 11, 2014, Chemical Dependency Lecture. Hello everyone, my name is Bret. I'm a registered nurse. I'm giving you this presentation on chemical dependency in the healthcare professional on behalf of the We Care for chemically dependent healthcare professionals. We have meetings twice a week down at the Lincoln County Church off Woods in Alvin and Willow Glen. I have some flyers up here and some business cards for Sharon Lutman. She's an RN and also an LMFT, and she helps start nurse support groups and encourage the diversion program to be created for registered nurses with the Board of Registered Nursing back in 1981. I do have a Master's in Science as a nurse educator. I'm also a CCRN and actively work in critical care as well. So patterns of drug use typically start out with experimental use. So you try a cigarette, you may try to hit off a joint in a party, you might have a sip of your parents' beer, and that slowly can progress to the social recreational use. People go out to the beach, want to have a Corona with your friends, you may not drink the whole thing, you might. That can also progress, as we talk more about this, into an intensified state, where you think you might need a beer or two before you go to the beach or go to the bar to hang out with your friends. Okay? Or you might think that just because you worked all day long, you really need to get out and have a drink. And eventually that can become compulsive. And this goes for drug, alcohol, or anything. Okay? When I talk about drugs, I include alcohol in that, right? Because alcohol is a drug. Compulsive use comes to the point where you have a dependency on it physically and mentally, and you absolutely have to have it and seek it out, and it becomes a part of your life. When people can only think about when they can get their next drug or pill or other kind of fix most of the day. So here's the brain, a wonderful, wonderful brain. In the brain is this area here, the ventral-tegmental area, and this is the nucleus accumbens. This is where we decide that behaviors that we do should be repeated. That's the pleasure and the reward center of the brain. In this area of the brain, dopamine, the neurotransmitter, is released in various quantities depending on what we're doing, what we put in our body, to tell us that was either good or bad. If it's bad, unfortunately, we really don't remember it too much. We like happy thoughts. So if it's good, we release dopamine on the pleasure reward center, and that builds pathways in our brain to tell us to do it again. There's a problem with that, as I'm going to talk more when we talk about dopamine release. Stress and alcohol, when a person uses alcohol to relieve stress, they're self-medicating. So I'll tell you now, if you go home after a long day in clinical, a long day in school, and you decide you're going to take a Benadryl, an Ambien, have a glass of wine, smoke a cigar, those are all drugs, that's self-medicating. So just call it what it is. Okay? I'm not saying it's good or bad, just saying call it what it is. Because that's what we're doing. At first, the reward circuits are able to function normally. Okay, so we get a little burst of dopamine. Let's take a donut, for example. You eat a donut, oh, it feels good. It returns back to normal pretty quickly. Okay, it feels good, you don't go eat a whole dozen donuts. Unless they're warm, then you might do it less. But with repeated exposure, this is where we start to build up tolerance. Repeated exposure. The responsiveness of the circuits in the brain start to change in that state of physiological stress. Usually takes about 50 instances of something to change a neuron into a permanent memory or action. Okay, that's why they say you have to repeat it, repeat it, repeat it. So once you do something over and over, changing that habit, whether it's a good habit or a bad habit, becomes difficult. So the spiral of dependence can grow as alcohol creates more stress on the body. Because alcohol is not only an anesthetic, right? It's an anesthetic, it's a depressant, it's a very, very powerful drug, and it's also an astringent. And it takes a lot for your body to detoxify alcohol. That likes it because it's 170 calories per ounce. That's why you think you get energy, because you are. It's not a stimulant per se, but it does give you energy. But it stresses your body. So in some of the theories of addiction, we talk about dopamine and reward levels in the nucleus accumbens that I showed you in the previous slide. So if you look at these as dopamine units, okay, if you eat a nice meal, you put out about 150 units, nice steak, body says, hey, you should eat that nice meal again. This is how McDonald's and Burger King and people like to play. Hey, well, how's that spike up your dopamine release in your brain to get you to eat more of this stuff? Sex is about 200. Pretty good number, right? You know, hey, people need to procreate. If it didn't feel good, we wouldn't be here. And then nicotine, smoking or chewing tobacco, is about 225 units. Morphine, about 200. But look at cocaine. It's about 350. So that's going to make you want to do cocaine more often because it feels a lot better than morphine, nicotine, sex, or food. Now look at amphetamine. 1,000. Very, very powerful, very, very addictive because it has a humongous dopamine release in your brain, telling you to do it again. And depending on the way that you ingest it, intensifies that release even more. People think that IV drug use is the worst, when actually smoking any drug is probably the worst, whether it's inhaling alcohol, smoking methamphetamine, or crack cocaine, or marijuana, because you have this huge vascular bed, you're just dumping the drugs into your bloodstream. So think about smoking drugs as much worse than IV. There's problems with the IV drug use. If you want to talk about addiction potential in the brain, it's smoking. Everybody get that? Okay, potential for abuse by risk potential based on how dopamine is released in the brain and that pleasure reward center and other neurotransmitters. I'm not going to leave out serotonin and other ones, but I'm not going to make this a chemical class. We're talking about how it affects your brain, and then that's going to go into behavior and how it affects you as a healthcare professional. So stimulants would be number one, followed by opiates because they're more of a central nervous system depressant, but they make you feel good. They help relieve pain. Alcohol and marijuana are about a 3, neck and neck, okay, on the feel-good scale. And then hallucinogen would be 4. And there's probably a pretty good gap between 3 and 4. So theories of addiction. So as I talked about, instead of eating, drinking, making love, drugs are going to tell you that you need to take them in order to survive. Like with the amphetamine scale of 1,000, if you do enough amphetamine, you're going to forget about food, sex. Repeated use of the drugs and alcohol is going to saturate that brain and reward pathway. Okay, so it's going to get into a cycle, a loop. All it's going to think about is how to get the next one, what to do about the next one, how to cover up behaviors you did to get the next one, and then go get the next one. Whether it's a drink, methamphetamine, cigarettes, food, gambling, sex, buying shoes, whatever it is. That reward pathway in the brain is the same. Because at the bottom molecular level, we're just big bags of chemicals, right, powered by electricity. We're not talking about you, me, or her. We're talking about chemical reactions in our life. Persons become conditioned to the intense levels of that stimulation that we talked about, and the normal levels of natural rewards are no longer pleasurable. So this is a problem when people get into recovery. And they're so used to that intensity that smelling the flowers or seeing a cat purr don't give the pleasures that they used to. So it takes time for the brain to recover from that before they'll actually feel it again. After chronic use, reward pathway neurons are depleted, so nothing is even pleasurable, not even drugs. No addicts talk about this. Well, let's tell you it stopped working for you. Like the alcoholic will drink when they're on their last leg. They will drink to stay alive. They're not getting drunk. They're not getting happy. They're fighting off the shakes. They're fighting off of the detox because they're in a perpetual state of detoxification. If they don't put more in their body, they're miserable. They feel like they're going to die. And to interject, there's 2 drugs that will kill you, and that's benzodiazepine withdrawal and alcohol withdrawal. The other ones will make you feel like you're dead, or want to die, but they won't kill you. Seizures will happen with alcohol withdrawal. That's why we give benzodiazepines. Okay, so factors in the healthcare setting that increase the risk of addiction. On this 13 scale, let's see how many of these you fit. 1, expected to be a caretaker. 2, you have abnormal working hours and shifts, prompting the need for sleeping aids or stimulants like coffee. I'm self-medicating with coffee right now. I work tonight. Sacrifice of family time when they call you to come in. Hey, we're short. Can you come in and help us today? Hard physical work. Difficult mental work. The element of being in control. Little emotional support, because we're supposed to toughen up. We really can't show our emotions. Especially with family, we get home, they can't understand it unless they actually do it themselves. High stress levels. You have the constant need for updating your skills. You have a lack of recognition. This goes back to when nursing first started, as a angelic kind of trade that we do. So we shouldn't get any recognition. Working with difficult patients. I talked about the alcoholic detoxing, which I work with frequently. Easy accessibility of drugs. I don't care what kind of system you have in place, people can still get their little hands on them. And then acceptance on some level as a nurse to self-diagnose and self-medicate. Oh, my knowledge of pharmacology, my knowledge of drugs, my knowledge of myself. I'm the best person to decide what I need and when I need it. And that's a recipe for disaster. We add that with the factors in the health professional, that's you, that increase the risk of addiction. One, the type of person who places others' needs before his or her own. Anybody in here fit that? Okay, you wouldn't be here if you weren't, I hope. And the use of denial in the work setting. I'm going to spend a little time on this one. People hear the word denial, and I'm not sure if they really understand what it means. Some people may think it's a river in Egypt. It's not. Denial has 12 different forms. Okay, you have major and minor forms of denial. And denial is a double-edged sword. Most people you can talk to might think it's negative when you say you're in denial. Think about this. When you're driving down the freeway and all those cars are going by you, and you kind of tune them out. You pay no attention. You know they're there. You're driving down the freeway, but your head doesn't explode because you're using a certain amount of denial to separate yourself from that element. Just like when you take a small child and you need to give them a vaccination, and you tell them this is going to hurt, and you know they're going to cry, but you do it for their own good. You have to use denial to separate yourself from that. If you're in the middle of a code and you're freaking out, you're not doing any good as a team, and they will throw you out. You have to use a certain amount of denial to separate yourself from that and get into a little robotic sense and save that person's life. Okay. So it's a double-edged sword. Denial is used for good, but the amount of denial reinforcement we get to use it for good can turn on us for bad. Does that make sense? 18% of health professionals are heavy drinkers and use alcohol to deal with job stress. I used to hear stories about people from the ER, the unit, go out after work and have a bunch of drinks. Well, they're going out to self-medicate. You may not hear about people running off to go have a heroin party at the hospital because that's not looked upon highly. But alcohol is legal and it's socially acceptable. And the numbers vary depending on your specialty. Especially when you talk about doctors and anesthesiologists, and those numbers get higher and higher. Many health professionals come from alcoholic backgrounds. Okay? They kind of develop a helper role or a scapegoat role, where they're trying to be a people pleaser because they may have a raging alcoholic or abusive person at home that has an addiction. Spouses are commonly alcoholic. Unemployed women as a group have a higher rate of alcoholism. Nurses are givers of care, not receivers. So we think we need to toughen up. And alcohol makes us feel better, helps us deal with the lack of recognition. For the type of person who wants to be a perfectionist. Anybody fit that bill? You guys competitive in here about your grades? Who argues about that one question on the test and get that extra half a point? That's so. I know, I've been there. I'm still there. Belief that knowledge of pharmacology can lend some sort of protection. Oh, I can take a Benadryl, I can take an Ambien and have a glass of wine. The label says use caution when operating machinery or motor vehicle. It doesn't say don't do it. We can rationalize, which is one of the forms of denial. You guys can Google that stuff and learn about it. Okay, so this is absolutely for you to know yourselves. Okay, you can take this information, you can put it away, you can pass your test, and you can forget about it. It may help you someday. I'm not saying you're going to become addicts if you do these things. But it will help you if you know somebody, a coworker, a family member, or somebody that you can help. Typically, we don't wind up helping ourselves. We usually have somebody else help us, or we're helping somebody else. So use this information to help guide yourself as much as you can, but with others, okay? So denial and the problem. All health professionals must learn to employ denial or self-deception in order to work with the sick and the dying. It's inherent in our job role. Basically, we become actors. How do you hold somebody's hand while they're passing away and not have some feeling of emotion, some emotion of sadness or grief, especially repeatedly? Not everybody makes it. People have poor outcomes. We hear about horror stories with family environments we send people back to. People coming in with decubitus ulcers. They've been at home for months and months, and the family takes care of them, and they come in often. And you do everything that you can. How do you separate yourself from that? It's high risk using denial for that. We learn to tell ourselves we're not tired when they haven't slept enough. Right? A little more coffee, another Red Bull. Last couple of years, they got these energy shots, a 5-hour, pop one of those down, caffeine pills, nicotine is a great stimulant. It's less favored in healthcare anymore. We harden ourselves against the cries of patients undergoing painful procedures, or even calling out, help, 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 in the demented patients. We tune out call lights and call bells. We use denial often, more than you would think. We put aside our personal problems when we walk into the hospital. We leave them in the glove box. We don't take our personal problems to work. We're there to take care of somebody else, not get care for ourselves. We try to put aside hospital problems when we go home. Typically, our family member is not in the healthcare profession anyway, so anything we said about it, they probably possibly could not understand. They may try to be empathetic, but until you do our job, you don't know what it is. You have to do it on a daily basis to understand it. The same technique used unconsciously allows us to deny our own painful addiction. Is the problem. And it gets hidden and buried. Denial is compounded by denial of the family, friends, and coworkers who are fearful or shameful of the problem. They often say, oh, my so-and-so, my sister, my brother, my husband, my wife is a nurse. Oh, she drank 2 bottles of wine in the last hour. She's a nurse. She knows what she's doing. She broke her pinky. She's been taking pain pills for 6 months after it healed. Well, she's a nurse. She knows what she's doing. It's scary because people look up to us. When you get put in an element of authority, people look up to you. It's really hard for people to help you. They think you're beyond reproach. And that's a setup. Bad setup. Reactions like ignoring or helping the addicted professional work speaks volumes about the profession's ignorance of addiction. Not to put anything against doctors, but I don't know if they have maybe about 8 hours of education on this. They're focused on other things. Even as nurses, I don't know how much of this you're getting other than the 2 hours I'm here with you today, or what you could read in your books. But it's more prevalent than you would think. Think about this real quick. The United States was founded on religious freedom, and tobacco, and slavery. Now, are there any elements of addiction in that? Denial of another human being's freedom, using stimulants. The rum runners come up from the Caribbean, Alcohol is prevalent up until the first prohibition when they tried to outlaw it, which didn't work. Yet we still fight about what drugs we can make legal or illegal. Now we have a prescription drug epidemic. So let's think about that. We're not talking about 1% of the population. We're talking about a very large percent of the population. They're either addicted or they're being cared for. Talk to anybody, and you probably don't have very many degrees of separation before you run into an alcoholic or an addict, or somebody with a shopping problem, or gambling problem, or smoking, or something. That's what we're talking about. We're not talking about the guy with a paper sack with a bottle of booze in it living under a bridge. They're out there too. There's your 1%. The rest are among us. Okay? That one clear? Cool. All right, declare Bissell's profile of the chemically dependent nurse. You ready for this one? We're in the top third of their class. Earned or were earning degrees beyond their basic training. Held demanding and responsible jobs such as supervisors, administrators, charge nurses, assistant head nurses. Were highly respected for their excellent work. Were ambitious and achievement-oriented. Normally started using drugs legally, usually as some form of self-medication. It was alcohol or a sleep aid or illegal stimulant. Would use drugs in private. Tended to use legal medication rather than street drugs obtained from legitimate sources as long as possible. Dentist, doctor, wherever they can get them from. And the average age of the disease manifested at about 40 years of age. Now most of these things, I think, is anybody not aspiring to any of those? At least, except for the bottom 2 or 3? I think you might all fit the category, right? I don't think you'd be here if you weren't. So that's the profile. So we're all at risk. Addiction doesn't care where you're from, how much you make, what degree you have, what color you are, what planet you're from, or any of that. It's an equal opportunity destroyer. Equal opportunity. And you're at high risk because you're doing this. This isn't to scare you, but to make you aware. All right, we have barriers to getting help. The health profession as a whole is very judgmental. Now, the care you give to your patients should not be judgmental, right? Non-judgmental care is what we do. But when you look around and you talk with your coworkers, it's very judgmental. So-and-so didn't do this. So-and-so left a dirty bed sheet. So-and-so gave this medication 5 minutes late. Very judgmental. Look at this person. Oh, look at that frequent flyer. They can't tell the patient that because that's wrong. But you'll talk to each other. So watch how you talk to yourself and how you talk to other people about things like that. Take care of a lot of addicts detoxing. Get a lot of people in, oh, so-and-so has lung cancer. All of a sudden you're going to see a stigma associated with smoking. But in the next bed, a woman with breast cancer is hailed and regarded highly. They both have cancer. Because one might have smoked and got cancer. Who knows? Could have been from asbestos, they got mesothelioma, or something else totally unrelated to smoking. Their spouse could have been a smoker their whole life and they got cancer from secondhand smoke. We don't know. But we want to jump to the judgment right away. We have to make judgments all the time. We can't do our job if we don't. But we don't need to be negative and judgmental. There's a difference. Health profession has the idea that knowledge can fix the problem. I can tell you from personal experience and that of hundreds of others I've dealt with, and know that all the knowledge in the world does not help you. There's a saying that a belly full of booze and a head full of AA is a big problem. They can talk it all day long. You can memorize chapter and verse. But without application, it's worthless. Here's a big barrier, fear of problems with the license. If you ask for help, people not knowing that there is help available and your license isn't subject to be put on hold, revocation, removal, suspension, or any of that. The problem comes is when you don't seek help and you get into trouble and it's too far gone. Then you're going to get the help whether you like it or not, if you still want to be a nurse. We're going to talk about that at the end of this. Acknowledging the problem is admitting that they've lost control. You don't want to feel less than. You want to feel empowered. You don't want to be looked at as that white cat nurse, Florence Nightingale, walking down the hall that everybody hails. They call us in for help. They want us on all the committees. They want us to take care of the most critical patients. We seek our advice. We're mentors to our peers. We don't want to lose that. There's a feeling that we can have 1,000 attaboys and one perceived mess up. They're all gone. They don't count anymore. I talked about this a little, lack of optimism about treatment by nursing management. I mentioned earlier that we see very sick people. We see patients that are detoxing. We see people that are homeless. We see what drugs and alcohol do to society on the most horrible side of the scale. Rarely do we see the person come back in that says, I have 30 days, 6 months, a year, 10 years, clean and sober, and what they're doing with their life. That's not the demographic that we deal with. We always get to see the bad. So, understandably, nursing management would expect that treatment would probably not work even for their nurses. There are some places that do get a lot of nurses, either on probation and diversion, and they do see that a monitored nurse can come back and be productive and lead a healthy life and lifestyle and be productive as a bedside nurse, or whatever capacity they may be in. But it's still taking some time. Now, diversion in California, as I said, 1981, and there's still facilities where you're probably not going to get a job if you're on probation or diversion. That gets us back here to the fear with the problem of the license. You make good money, you get used to a certain lifestyle, and you don't want to lose that. So it gets hidden even more. You see how the loop gets worse and the noose tightens around your neck? Once you get in it, you can't get out. It's a very difficult position to be in. There's help. So there's enforcement and probation. So something happens at work. Typically, if you get injured, you're probably going to go down to the ER. They're going to do a drug test on you, regardless of anything, because the hospital needs to cover themselves. It could be from a family member. It could be reviewed by the pharmacy, looking at your number of narcotics you remove and things like that. What is your pattern of medication administration? A complaint would go to the Board of Registered Nursing. And then they would do an investigation, and if they determined something is needed, they would take legal action. So if you're impaired at work, that's a violation of the Nurse Practice Act. Everybody here read the ANA Code of Ethics with interpretive statements? Nobody? It actually talks about chemical dependency in there. It's kind of buried, but it's in there. It talks about how we should act. I encourage you to read that, take that forward, to be helpful, not judgmental towards your peers or yourself. I have the most respect for the people that acknowledge that they have a problem and do something about it. I don't care. Think of it this way. You eat too much, you eat a lot of donuts, you get diabetes, you get treatment, you lose weight, you get better. How is that any different than somebody who quits drinking, gets healthy, and goes back to work? It's a disease. The American Medical Association determined that alcoholism was a disease in 1955. And they still view it as a social problem. Legal action can happen. There's nurses that will take drugs from work, and so that's a completely different area where they would have to deal with. There's a board registered nursing and licensure. So if somebody took drugs from work and they got caught, they not only get reported to the board and their license gets disciplined, but they have to deal with legal applications, which goes right to the local district attorney. So they can do jail time, fines, things like that. Probation monitoring would occur. I'm going to talk about the differences between probation and diversion a little bit. This is primarily probation. This would be, an investigator submits a written report of the findings to the BRN for review, and they'll look for violations in the Nurse Practice Act, write up a legal writ, a formal complaint, which is public record. They will serve you with that, and the Attorney General usually will be the one that prosecutes you through the BRN. So if there's any hanky-panky with stealing drugs, that's the local DA. But for us, it's the State Attorney General. I had the pleasure of meeting one. I got to see her last year too. It was really cool. I got a big hug from her. What's that tell you? So, goes to the Attorney General. Possible outcomes: you can have your license revoked or suspended. You can accept a voluntary surrender of your license, which means we're going to take it, but we're going to tell you it's voluntary. They can put your license on probation, or you can cite and fine you, or a combination of all four. Let's see if I talk about probation on the next page. So probation, it creates a contract with the Board of Registered Nursing. You get assigned a probation officer or probation monitor to comply with your contract. Usually it's an undetermined time. It's left open. Typically it's 3 to 5 years. Could be longer, depending on how a person does. It's involuntary. If you want to keep your nursing license, you will do probation. They will tell you this. You can go become a mechanic or pound nails or something if you want. But if you want to be a nurse, they'll tell you you can do that. The complaint will always be present on the professional record with the BRN. You go on the website, it'll show up, tell you exactly what you're accused of, what they did to you, and all that. Forever. It's public record. Successful completion will restore your license with no restrictions, so you'll be able to practice actively as a registered nurse anywhere in the state of California you want, or go on with your life once you complete probation. But you still have the public record that anybody can search on. Typically, probation happens with people that get caught impaired on the job. Could have been, I know, gal, hear people, they were on vacation and they smoked some marijuana and they came back and busted their pinky and they got drug tested. It had been 2 weeks, they were on vacation. Well, guess what? Presence of the drug is grounds for discipline, not whether you were intoxicated or not. So, you go to the dentist and you take a Vicodin and stuff like that, I suggest you don't go work. It's something to cover for you. I know it sounds harsh, but if something were to happen, you have no recourse because you showed up under the influence. Not to be impaired, showed up under the influence. If something happened where you had to get drug tested and they found the drug in your body, that they could say was evidence of impairment. Follow me? It's like if you drove home after a night shift, and you're tired, and you have any medication in your body, that's enough to tell you it was impairment. Because it's there. The whole, oh, I'm sleepy thing is out the window. Doesn't matter if you were truly sleepy or not. Make sense? So that is probation. And I'm going to talk more about how probation and diversion are similar here on the next couple slides. On the diversion program, and what we talk about, we're not about diverting drugs from the hospital. We're talking about diverting you from the criminal justice system. We're talking about diverting you from that local DA, the Attorney General, the public record, for a permanent record on your license to a recovery. Big difference. we're diverting you from the criminal justice system. The diversion program is voluntary, meaning you say, I have a problem, I want help. That's how it's voluntary. You can quit at any time, but there's repercussions. It's voluntary, it's confidential, within reason. You still need to be able to be monitored, you still need to be working. Okay. Some people have to know about it to be able to monitor you, but otherwise it's confidential from the general public's viewpoint. Is for RNs whose practice may be impaired due to chemical dependency and mental illness. You can have depression, PTSD, whatever it may be. Remember, PTSD is an injury. A lot of vets coming from the Middle East with PTSD. So chemical dependency or mental illness. It can be a self-referral, hey, I need help, or it can be a board complaint. The same complaint can go in, hey, there's a problem with the hospital, so-and-so we think is impaired on the job, they send a complaint to the board investigates. You will know about that probably right away when the board investigators are on site, and that's probably going to give you the number here on the next slide that says you need to call them and self-report. So hopefully they will let you into diversion. They don't have to, and they don't always offer it. There's people that get one DUI and they just put them on probation. Some people get one DUI and they say, we'd like to offer you diversion, and they say, well, we don't have a problem. Well, guess what? The length of time and the things you need to do for probation and diversion are about the same, except probation stays in the permanent record. So, I know that going the diversion route or probation route, you both have to get into recovery and show evidence of that. So why not go all the way and then have a clean future? Because you're going to do it anyway. But some people are hard-headed and don't want to listen to that. They want to do it their way because they know better, right? That's why they're in trouble. Okay, so self-report referred due to a complaint. It's usually a 3 to 5 year program. Usually start out in what we call a pre-DAC, or Diversion Evaluation Committee. Pre-DAC, they tell you you need to go to treatment, inpatient, rehab, whatever. You get a little general contract before they bring you into your first meeting with representatives from the Board of Registered Nursing, a psychologist, maybe your Attorney General or not, and other people there to review your case to see if you're a candidate for diversion, meaning you're ready and willing to make changes to get into recovery from your addiction and then go back to become a practicing nurse. This is not for the people that want to skirt the law. This is not the people that just want to avoid having a black mark on the record. They're professionals. Most of the people on these boards, the diversion evaluation committees, are addicts in recovery, so they will know if you're BSing. So diversion evaluation committee, you usually get your first one as soon as you get out of treatment and you're able to go. After that, they may do them at 3, 6, 9-month intervals. Probably see more frequently in the beginning of the program. They will ask you to go politely and commandingly to Alcoholics Anonymous and Narcotics Anonymous meetings every day, daily, not 5 days a week, 7 days a week, every day until further notice. Usually 6 to 4 months, depending on how you're doing with the recovery. A nurse support group weekly throughout the term. Therapy, if they feel you need it. They evaluate you on your intake, and through the program they might tell you to go to therapy as well. And outpatient or inpatient rehab, depending on the severity of your issue, they may send you inpatient rehab for 30, 60, 90 days. It might take you away from your home environment if it's deemed unhealthy, and you may need to stay in a sober living for 3 to 6 months, depending on the severity of your offense. No work for 3 to 6 months. How am I going to pay for all this? I'll find a way. Typically, being an addict in recovery and working as a nurse, so you can get disability for up to a year, until your money runs out. It's usually a year, a little bit after a year. But people want to get back to work right away, and that's the worst thing for you. You want to get to the nitty-gritty of the problem and help you get better before you go back to work and do it all over again. That's the whole idea behind this, and the length of time that you're in the program. Narcotic access restoration varies. Some people, if it was like DUIs and things, they might be able to go back to work and get their narcotic access in 3 to 6 months. At the end of their term, who knows? It just varies on the offense. Some may be able to go back to work doing non-patient care versus patient care right away. Because even if you don't have narcotic access, there's ways to get those in patient care areas. So you may need to do case management and things like that before you go right back to work. Worksite monitoring. So our contract and the bubble form is filled out by probably your immediate supervisor, must be a nurse. Seeing if you're impaired, you show up to work, you're fulfilling your contractual obligations. You're not working night shift usually, you're not carrying narcotic keys, you're not in supervisory roles, you're not working double shifts, and those things. They want to tightly monitor what you're doing. I'm going to go back up here. The random drug tests, you're going to do a minimum of 18 a year. You've got to call in every morning. An 800 number to see if you're selected for tests, and you must test by the end of the day. And we'll give you sites even when you're traveling. When you're traveling, you have to ask permission to travel. And then you have to still be able to test when you go to those travel destinations. And they can and will disrupt your travel. And you will miss flights, probably, but you will survive. That's if you want to be a nurse. Still, these are the things you must do, and many people do it. Naltrexone, sometimes they may allow people to take naltrexone if they have opiate addictions. Typically, send an AA and NA and rehab facilities and therapies and support groups are sufficient without having to further medicate. We want to get away from medications as much as possible. Now here's the beauty of the diversion program. Besides you get healthy, this is what most people want. And that's on completion, all record of the diversion participation and the original complaint are shredded. There's no public record. So when you go get a job down the street, they don't Google you on the BRN website and find out that you have a complaint against you for stealing drugs. Or they found you in the bathroom with a needle in your arm. Okay. Early termination to withdraw from the diversion program, a complaint sent to the Board Enforcement Program, which is diversion. And it usually reverts in probation, depending on what the original complaint was. They could revoke you right there. So you're done. Sounds fun, right? All right, so we'll talk about application for licensure. They put in next spring? Or, okay. When you apply for your license, most of you are quite young. You must include all misdemeanor as well as felony convictions. Don't care if it's shoplifting, DUI, drunk in public. If it's over $400 on a traffic fine because you did 120 down the freeway, all that you can think of, remember, and go down to the Sheriff's Department and get a rap sheet. If you have anything, any encounters with law enforcement, please report it up front. It will help you. They will see it. Even if you had a record sealed as a minor. You're not dealing with the public where they can be sealed and expunged. You're dealing with a government licensing agency who can see all forever. So even though at the end of these beautiful things, they're expunged and released to the public, there's that little cannon in the Department of Justice that knows everything about you. So you might as well tell them everything about you. It will make it easier. There's people that get one DUI and they go to nursing school. Years ago, myself included, had to do a whole packet, letters of recommendation, and send all these things in and give all the dates of every arrest, every fine, failure to appear because I didn't pay the turn signal broken ticket on my motorcycle, all that stuff. And then talk to somebody at the Board of Registered Nursing before they decided I could take my NCLEX. That was in 2007. It's harder now. Everybody's fingerprinted. Everybody that's renewing needs to be fingerprinted. Everybody gets a full background check. If there's anything that they don't know about, it's going to be delayed and you're going to be questioned on it anyway. So just be upfront. There's people that are graduating that have issues or have graduated. I know a few of them. It takes them a little longer to get their eligibility to test or get their license, but they do eventually get it if they're above board and up front. Questions on that? We'll have plenty of time afterwards to answer all kinds of good stuff too. Right. So, reporting prior convictions or disciplines against the license is absolutely necessary if you were in a different field, you were an RT and you got in trouble and now you want to be a nurse. You have the different boards talk to each other. If you're an LVN and now you become an RN, you're in trouble with the LVN board, the RN board knows, the RT board knows. Mechanics and consumer affairs, it's like all under one umbrella. It might take them a minute to talk to each other, but eventually it will catch up. So just tell them up front. Because it says applicants are required under law to report all misdemeanor and felony convictions. DOI must be reported because it's completely related to your ability to perform on the job. Convictions must be reported even if they've been expunged, or even if a court-ordered diversion program has been completed under the penal code or the vehicle code. You still got to tell them. Again, confidential except where needed. Your worksite monitor needs to know you're in diversion or they can't monitor you. That kind of stuff. You will submit fingerprints with your application. Go down to the live scan. So they'll run you through the Department of Justice. And they will know all, whether you tell them or not. And then here's a number, 408-235-1178. Have flyers up here and business cards for Sharon. So you can call the We Care hotline. We do have a website as well. Diversion program contacts. There's a contractor that the Board of Registered Nurses uses for the diversion program. They don't administer it themselves. Okay, it's a private contractor. They do communicate back and forth, but this allows it to be more confidential. So it's managed by Maximus, which is up in Sacramento. So they're great people up there. They're there to help you. And then the BRN Diversion Program Manager, I think it's still Millie Lowry. There's a number there, the 916 number. So if you know of somebody or yourself and you get into a tight spot, diversion may be a way to get the help you need before it gets worse. Now diversion, I'm going to tell you, only for registered nurses. You must already be licensed. Or for probation, they can put you on if you're an applicant, as a condition of you being licensed. But with those, I don't think there's a complaint. But this, they find information and they want your information before you're licensed. All right, so here's our website at the bottom of the screen. And we provide a safe, supportive environment with meetings on a weekly basis, facilitated by healthcare professionals who have experience in chemical dependency. So Tuesday at 4 and 5:30 at the Lincoln Glen Church on Bookson down in Willow Glen, and then Wednesday morning at 10 a.m. Please call the phone number first. You can't just pop in and say hi. It is for addicts and alcoholic healthcare professionals. We do occasionally get dental hygienists, respiratory therapists, and things like that, but they're primarily nurses. It's a nonprofit established in 1981. There's not a fee to go to this nurse support group. Other nurse support groups in different areas do require a fee that's paid along with other expenses. Work with the Board of Registered Nursing Program in the state of California, so it meets all the reporting requirements that the BRN expects for people in probation and diversion. And we're confidential, and no attendance will be acknowledged without your express written consent. So nobody there would even be able to tell you, anybody else that you were there.